Okay, so this week we are going to cover real quickly health promotion. So this is not something that is covered very well in your book. We cover little bits and pieces, but not all of it. And some of these things do show up on HESI. So I wanted to make sure that we touched on these real quickly. And then most of our time today will be spent doing our Kahoot that covers a little bit of everything that we've touched on in class. So we're going to start with communicable diseases. These are things that are common in our world today and end up causing disease. Some of these are ones that we have to report to the health department or the CDC. And the CDC is the one that really runs the show when it gets to figuring out what immunizations and vaccines we need, how we're going to prevent these diseases. So they're the ones that are providing all the guidance for this. So the first one we're going to talk about is rubella and measles. You'll see with pretty much every disease that we talk about today, it is going to require contact and droplet precautions for most of these. So measles is highly contagious. A virus that gives us neurologic problems, and if it goes untreated, it can lead to death. So these patients have photophobia, which means they are light sensitive. They also have Koplik spots inside of their mouth, so little white spots. And they end up with a rash that begins on the face and then spreads downwards. Measles are easily preventable with our MMR vaccine, which gives us measles, mumps, and rubella protection. And we give this in 2 doses, one just about 1 year of age and one right before they hit kindergarten, so 4 to 6 years of age. Chickenpox, we're all pretty familiar with, varicella zoster. We know those characteristic skin lesions. They start in our core and then they spread outwards. And they have this progression that they go through. They start being just a flat rash and then they end up going all the way through the pustular stage, and we are contagious until those scabs crust over on those rashes. So this is one, again, spread by direct contact or droplets. This one can also be spread through contaminated objects. So if you have one of those pustular stage lesions and it pops and you rub your teddy bear across that, the pus from your lesion on your teddy bear can now contaminate the rest of the family. So making sure that we're keeping a close eye on those lesions, keeping everything nice and clean. Again, we can vaccinate against chickenpox at 1 year and 4 to 6 years of age. German measles, the most important thing to remember about those is that they can cause harm to an unborn sibling. So if you have a child with German measles and you happen to be pregnant, you need to make sure that you isolate yourself from that child so that we don't have risk to the unborn sibling. So lots of birth defects can actually cause death of the fetus if they come into contact with it. And with German measles, we have a rash that only lasts for a couple days. So that's another thing that's unique to German measles or rubella. For pertussis, that's our whooping cough. It is a respiratory infection that normally happens in infancy, caused by our gram-negative bacilli. We start with just those common upper respiratory symptoms, and then we end up with this very characteristic prolonged cough. So crowing or whooping on inspiration. So every time they breathe in is where you hear that whoop. We treat this with erythromycin and then symptom management. So things like cough suppressants at bedtime will really help to allow that child a good amount of sleep to recover. Some complications of whooping cough are pneumonia, hemorrhage, and seizures. For mumps, we have these generalized symptoms. We have fever, headache, malaise, or just not feeling well. We have parotid gland swelling, which is the big one. and requires them to be on bed rest as long as that swelling is present. We can also have some submaxillary and sublingual infections, so in our jaw and under our tongue, and it can lead to meningitis if it goes untreated. So for this, we're going to make sure that we are doing pain control for that gland swelling and tenderness, and as well as any pain associated with that infection in the jaw, and then keeping our fevers down as well. We did talk about pediculosis when we did our skin section. So this is a lice infestation. We know that we can have lice in different areas of the body. Our treatment is going to be directed at killing those adult lice, getting rid of those nits or those eggs. And we can either remove them manually or use that shampoo that has permethrin in it, same medication that we use to treat scabies. We also need to make sure that clothing, bedding, anything that comes into direct contact with that child is treated as well so that we don't get a reinfection. So anytime we have a communicable disease, we need to make sure that we are isolated during the time that we're contagious. We want to treat any fever with a non-aspirin product. So acetaminophen or Tylenol is going to be your best bet so that we're not causing Rye syndrome. Some of these have to be reported to the health department, like we talked about. So making sure you're aware of which ones require reporting. And then we want to prevent that child from scratching. We know anytime we scratch an itch, then we can cause skin breakdown. So we want to make sure that we keep our nails really short. We may have to put mittens on to keep them from scratching. And then we can do topical treatments like lotions or soothing baths to help prevent that itching. Also, we can use Benadryl, that diphenhydramine, for itching. And we want to make sure that we are doing really good hand washing so that we are not spreading the infection to others. We're going to hit the highlights on nutrition. We've kind of talked about this all term, but nutritional assessment is really important, not only the child's eating habits, but the family altogether. We know that iron deficiency anemia is our most common nutritional deficiency. We see it as these infants are weaning off of their iron fortified formula. Then we see it come back again in adolescence as we are hitting that growth spurt when we go into puberty. We also have some common vitamins that we have a hard time getting in our preschool and school age children just because of their limited variety of intake. So vitamin A, C, B6, and B12 are commonly deficient in our preschoolers and school age kids. And then our adolescents, again, have that increased growth requirement. So they need more calories, protein, zinc, calcium, and iron to help support their growth. There's a couple ways that we can assess our nutrition status. The first one is looking at our dietary history. So a 24-hour recall is exactly what it sounds like. We're asking them to tell us everything that they had to eat or drink in the last 24 hours. It's a very short-term picture. A food diary is a 3-day record. So we record 2 weekdays and 1 weekend day so that we can see the difference between the week when everybody's at work and the weekend when everybody's at home. That way we get a better idea of what's happening throughout the week. And then a food frequency record is a standardized questionnaire that asks how many times a day, week, month a child consumes the 4 food groups. So very standardized, easy to get an overall picture of extended nutrition. So your food frequency record is going to be your big picture of their nutritional status. We can also do labs to tell us about our nutritional status, obviously looking at things like our metabolic panels. We can also look at our blood panels like hemoglobins, hematocrits, albumin, to see if we have these blood components somewhere that they don't belong. That might lead us to believe that we have a nutritional deficiency. We can also use our physical exam. So we can look at their skin, their hair, their teeth, their mucous membranes, all give us an idea of their hydration status, their overall nutrition. We can plot their growth on their growth chart. So we can look at their height, their head circumference, their weight. All of those can be used to ensure that we are getting appropriate nutrition. We talked about diarrhea in our GI section, so we know that's an increased number and decreased consistency of our stools. Can either be caused by a bacterial or viral infection. Rotavirus is going to be one of those viral causes for gastroenteritis and often requires hospitalization. We can also have malabsorption problems that cause diarrhea, as well as inflammatory diseases and dietary factors. So if we introduce something that the child's not able to tolerate, one of those signs can be diarrhea. We want to prevent complications like dehydration, metabolic acidosis, shock, and death. Obviously, you can see the progression there. As it gets worse and worse, we get more severe complications. We're going to look at our labs, looking for our loss of bicarbonate, sodium, and potassium as we're losing those in our stools. We can see elevated hematocrit and BUN as we're getting more and more dehydrated. We're looking for those signs of dehydration to start with, that poor skin turgor, not making tears, dry mucous membranes, weight loss, sunken fontanelles, decreased output. And those are going to progress into signs of shock if we go untreated. So we'll end up with a low blood pressure, rapid weak pulse, mottled color, and change in our mental status. So we also want to make sure that we have a good history of any exposure to illness they might have had, contaminated or undercooked foods that might be causing the diarrhea, and any changes to their diet. We're going to keep a close eye on our vitals and our I's and O's just to make sure that we are staying well hydrated. Obviously, following our orders for fluid replacement. We don't want to do a rectal temperature. Anything in that area can stimulate the rectum, cause more diarrhea to happen. So we definitely don't want to do that. Also, when we've got skin breakdown from loose stool, we don't want to be introducing anything else in there that could cause a perforation or an infection. Collecting our labs as ordered, and then making sure that we keep these patients in isolation until we can rule out an infection. When we are looking at our orders, we can expect to see things like oral rehydrating solutions like Pedialyte. We may change their diet temporarily to make sure that they're not having a reaction to a common allergen. And then we want to be careful about the types of liquids that we give them to drink. Things like grape juice, orange juice, apple juice, sodas have high osmolality, so they can actually cause diarrhea. And then anytime we are giving IV potassium, we need to make sure that we have appropriate urine output. When we're looking at our burns, we know there's many different types of burns and causes, and they are one of the leading causes of accidental death in our pediatric population. About 75% of burns are actually preventable. So complications we're trying to avoid. We know our kids under 2 have a higher mortality rate because they have the larger body surface area. They lose a lot more fluid through their skin, and they are not able to compensate for the volume shifts that we see in response to burns. We know that we have to follow
I'm
our.
sorry, Professor. Can we go back to the other slide?
Yep.
At the top, under risk factors for burns, it says male gender. I don't
Mhm.
know if you went over that or not. Does that mean that they're more susceptible, and why?
Yes. So males tend to be more apt
Risky.
to take risks.
Ah, gotcha.
So we have that that puts them at greater risk just because they're a little more adventurous and can be into some more risky behaviors than our females who tend to be a little bit more docile and shy.
Awesome. Thank you.
Yep. We do follow our growth charts, these burn charts that are made for us because we do have different stages of growth. We know that we don't always grow in a nice linear fashion, depending on our age. So that's why we can't follow the rule of nines like we do with adults. So we use either the pictures or the actual numeric tables to help us figure out how much fluid replacement we need and how many calories they're going to require. So along with our table, we can use the Parkland formula to calculate our fluid replacement and also our maintenance fluids. And then we're going to watch our urine output to make sure that we are on target. And remember, the rule of thumb for urine output is 1 to 2 milliliters per kilogram per hour. We also have to watch out for child abuse. Remember, we talked about the difference between abuse and neglect. So abuse is actually inflicting something on a child. Neglect is intentionally withholding something from a child. The biggest red flag is injuries or stories that don't match the injuries that you're seeing or the child's developmental age or skills. Sometimes we can see delays in seeking medical care. So we have a pretty significant injury and it takes parents several hours to bring the child in. That would be a delay in seeking medical care. We talked about bruises and fractures in various stages of healing. You may
Excuse
even.
me, Professor Star.
Yes.
I'm seeing this slide and it wasn't read in detail and there were some questions on the exam. I don't know, but it's strange. What
Okay.
you're talking about right now, there was some question on the exam that wasn't talked about and now I'm seeing it on this slide. So just take that into consideration, please.
Okay.
Thank you.
So we talked about bruises, fractures in various stages of healing. We know if we have bruises in different colors, then that means we've had multiple causes of injury. We can also sometimes have a very specific pattern where we can tell the type of injury for a burn or a bruise, if it was caused by a physical object. We can also see whiplash and shaken baby syndrome, bald patches if hair was pulled out. One of the other things that we frequently see is a child being frightened or withdrawn in the presence of their parent or another adult, in the case of child abuse or maltreatment. So we want to make sure that we are reporting all of these cases of suspected abuse to the appropriate agencies, making sure that we're documenting objective statements, making sure we're including everything that we're seeing about the child's injuries, as well as their interactions with their caregivers. Any photographs of the injuries might be helpful. We really have to work at reestablishing the trust between the child and their caregivers and helping provide support for crisis intervention. We briefly talked about poisoning, anything we've ingested, inhaled, or absorbed that ends up at toxic levels in our body. Typically happens around 2 years of age when we're starting to be more mobile and curious about our environment. And most of them happen at home. So we have to be sure that we are really being careful Ingestion is the easiest way for us to have an exposure to a poison. So we want to make sure that we are child-proofing our house, keeping all of these potential poisons out of reach and in a locked cabinet, so that we're not putting our kids at unnecessary risk. A lot of times in the event of poisoning, you will find the child really near the source of poison when it happens. We want to make sure that we're assessing for burns in our mouth and our pharynx, especially if we've ingested something that we shouldn't. Looking for those signs of respiratory distress, shock, anemia is another common one, GI disturbances. In the event that we have lead poisoning, we have early and late central nervous system signs. So the early signs of lead poisoning are going to be hyperactivity, aggression, impulsiveness, decreased interest in play, headache, irritability. Those late signs are going to be those severe central nervous system signs. So cognitive impairment, paralysis, blindness, seizures, coma, and death. So we're going to keep a close eye, especially respiratory, cardiac, and neurologic symptoms. Those are going to be the classic ones that we see. We want to make sure that they bring the container and the child into the ER as quickly as possible. We like to get treatment started within an hour of ingestion so that we can remove that toxin quickly. We're going to use their age and their weight to help us dictate our interventions. Obviously be in contact with poison control as soon as possible, either through their 800 number or their online information. We may do gastric lavage, activated charcoal, or other measures to neutralize that poison so that we can remove it from their bloodstream and their system. Remember, we don't use ipecac syrup anymore because it doesn't actually neutralize that poison. So we induce vomiting, but we're actually causing more damage because we don't have that neutralization. We need to provide lots of education, making sure that parents are aware of all of the things that a child can ingest for a poison, making sure that they're stored appropriately. Medications are in child-proof containers, out of reach, making sure that we're discarding unused medications properly, and that we're providing the appropriate adult supervision. And then any referrals that are needed. So that is it. That was our very quick review, so that we have time for our Kahoot here. So let me get this up and shared with you guys. So this is going to be a little bit of everything. Okay, we will go ahead and start. The pin is in the chat if you guys need to join later. So a Broviac is a central line. So not only do we have the risk of something getting into it if it becomes disconnected, but we also have the risk of blood pouring out of it since it is a central line. So our first intervention, if it becomes disconnected, is clamping that catheter. With cleft lip repair surgery, we've got a suture line through our lips. So we definitely don't want to be crying when we're recovering because we're putting stress on that suture line. There we go. So here we have a child with leukemia that has a central line and now a fever. So we want to do a blood culture from that central line so we can rule it out as the source of infection. So intussusception, that's where the bowel slips into itself, and is one of those conditions that can usually resolve on its own. So if we have a child that is scheduled for a reduction and they're passing stool on their own, then that means that it probably has corrected itself and we no longer need surgery. So we're going to notify the healthcare provider and see what our next steps are going to be. Six months, we're going to start with the introduction of rice cereal because it's the least allergenic. Then we can move on to strained vegetables, pureed fruits. We want to stick with those single foods at a time. What age can we introduce whole milk? Who remembers?
After 1 year.
Yep, after 1 year. Before then, we can cause GI bleeding. So whole milk is not going to be appropriate. We do not have teeth for sliced beef yet, so probably not a good choice. And then we're going to hold off on those fruit juices until they're drinking more from a sippy cup. We know with spina bifida we're at increased risk for latex allergy, and that is also a common component in balloons. So sneezing and a rash when we're playing with balloons is going to be that manifestation of that latex allergy. Middle ear infections, otitis media, can be caused by fluid pooling in the side of our mouth and then getting into our eustachian tube. Remember, they're very closely connected. So if we hold a child upright while they're eating, then we don't get that draining that happens. Getting our ears wet when we're swimming or bathing, that's going to be otitis externa. That's our swimmer's ear. Going back to our theorist, adolescent psychosocial development focuses on establishing that sense of identity. With rheumatic fever, we can have joint pain and swelling. So ambulating without restrictions will help to keep those joints moving and help alleviate some of that pain that they're feeling so they're not getting stiff. One of those suicidal risks is preoccupation of death. The closest correlation here with depression is going to be sadness. Orange juice is given with iron so that we increase our absorption. With impetigo, we expect to see those honey-colored crested lesions. So anytime you have a patient that's showing these signs of respiratory distress, not being able to speak, cyanotic, decreased shallow breath sounds, we're going to help ventilate them. The proximal distal development is development that starts at our center and works its way out. So we'd be able to have arm and leg movements before we'd be able to do fine motor skills with our fingers. If we had a cardiac cath on our right femoral artery, so our right groin, we would suspect an obstruction if we have a cool, pale, and blanched right foot. So below the site of insertion is where we're going to see those symptoms. Do a toddler in a spica cast. That's the one that goes pretty much from the waist down. We need something that allows them to be creative, keeps them in bed, and is not dangerous to their cast. So a soft hand puppet is going to be your best choice. With tetralogy of Fallot, if an infant goes cyanotic and hyperpnic, that's going to be a TET spell. We put them in that knee chest position. With DKA, we typically see metabolic acidosis, and our respiratory system tries to kick in with these small respirations or these deep sighing respirations to correct our pH and our bicarbonate levels. One more, guys. If we have persistent vomiting, we always want to be aware of our potassium levels. We know that's one of the things that we lose through our emesis. So having a low potassium, we're going to want to probably replace that. So it looks like Nunya is our winner today. Good